Okay, now we open the heart up, and here we can see the valves between the atrium and the ventricle. On this side is called the tricuspid valve because it's got 3 flaps, and between on the left side, the left atrium, and the left ventricle is called the mitral valve because it has two flaps to the valve there. But this is important. And you'll see these little tendons or tendinae which are acting to hold the valves. So they regulate the position of the valves. And these are actually regulated themselves by papillary muscles. So we've got like guy ropes in there steadying these. And the valve itself, it has cartilage in it. It has fibrous cartilage tissue in it. So now you begin to think, well, what's interesting about the heart? Because we've got muscle in there, we've got nerves, okay, we've got blood vessels, of course, within it. We've got cartilage, and we've got ligaments. It's a living entity on its own, isn't it? Okay? So if we turn the life support machine off, the body dies. But ironically, the heart will continue to beat. So who's the real you? So by the end of the day, you'll come to changing your ideas a little bit, because one thing is for sure is that there's a strong relationship between the mind and the heart. Okay? And what we'll come to the conclusion at the end is that we feel things in the heart, because we're going to learn the heart actually secretes a whole range of hormones. It's an endocrine gland as well. And it secretes feelings. So when we have a feeling of a stress or a problem or a nice feeling, we feel it before we interpret it in the mind and put words to it. So this heart-mind connection is intimate. You can't do anything. You can't have a thought without a feeling. And it's the feeling that comes before the actual putting it into words. So if I shock you, first of all, you feel the shock through your sympathetic nervous system, etc. And then you say, silly old fool, trying to shock me like that. Or you try and interpret it, and that's your brain kicking in, okay? So at that particular time, for that moment, the heart felt it first. And we'll see that you actually felt the impact of the shock or the emotion, and then you interpret it. Yeah. And experiments have shown this consistently with heart math, that the person experiences the feeling, and that the feedback is very much back from the heart to the brain. And it's not just the brain feeding the heart, it actually goes the other way as well, through the vagus nerve, because that's the main attach. And the vagus nerve, as we'll see, goes into the lower part of the brain, into the medulla pons area, and feeds up and down. And then probably from there, information goes into the higher centres. And it definitely goes via the cerebellum, because it's ipsilateral. It goes on the same side. And this is really quite tantalising to us at first, because we couldn't understand the relationship between which subscapularis was weak and the brain that was active, the left or the right brain. What you'll soon find this out is when we test a muscle, like the quadriceps, when we test the right quadriceps, we're actually activating, putting information in and motor out to the left brain. Okay? Now, from a proprioceptive point of view, this only occurs as it crosses over after the cerebellum. It crosses over through the thalamus to the opposite motor center, sensory and motor cortex. Okay? When we look at the organ relationship, it's ipsilateral. So when we come to look at the subscapularis, when we work on the left one, we'll be actually looking at the left brain. And when we work on the right one, we'll be working on the right brain. Okay, and that's the subtle difference. So you'll see what I mean when we come to actually demonstrating this. So in the heart, we therefore got all the tissues we've got everywhere else. We haven't got bone. Nobody's discovered bone in there yet, but everything else is in the heart. So controlling the firing sequence of the heart, this inherent rhythm, which develops so early on, occurs at the SA node, first of all, and then to the AV node. So this one is more to do with the contraction and regulation of the atrium, and then the AV node is more to do with the ventricular. And this sends fibers down the central centrum of the heart, septum of the heart, called the right bundle and the left bundle. That says right and right. So left and right. Okay. So basically what happens, this is called the bundle of His. Okay? And so the neurological firing goes down the left and the right bundles, and then goes round into the myocardium, or the muscle, in what is called the Purkinje Fibers. Okay? So it's very important that when the AV node fires, that the neurological sequence goes down both sides at the same time. Okay? If it doesn't, we get an irregularity. Okay? And so we'll get a split sound, which you can pick up dead easy with the phonocardiograph. So when you get a split sound on any of the valves, but particularly the first one, we'll see the shutting of the valve on one side here, the mitral is before the tricuspid, or the tricuspid is before, you'll say, it's a bundle branch block. And you'll know that that's going to respond to what I teach you a bit later on. Okay? So there'll be a remedy, hopefully, or something that you can say. Now, what's interesting, that each of these parts of the firing are inherent. You can ablate the first one, and many people do for atrial fibrillation. Okay, they have ablation of the SA node. And that's the one that is very, very sensitive to toxins, and particularly excitotoxins. So monosodium glutamate and aspartame are the things that fire this one off, you know. So any toxin which is an excitatory in nature can play havoc in there, but so can a lot of other chemicals. So when someone gets bouts of atrial fibrillation or tachycardia, and then they're all right again after a while, think this is something that's gone into the person. It's something they've eaten or drunk, because it's not there all the time. If it's there consistently and they're beating away at 160, 200 beats a minute, then you want to slow down. You're going to burn the heart out. And people will sometimes have ablation, but you don't want to have, obviously, ablation therapy unless it's really, because you're not getting to the cause. If you have ablation therapy and the person continues to drink Diet Coca-Colas and things, then they're defeating the object. You're just treating the symptoms, really. So when we come across bundle branch blocks, you'll say, bundle of His, it's an impaired firing sequence. Now, the AV node fires itself. So you can destroy the SA and the AV node will take over. But it takes over at a slightly different rate from the SA. It's slower, but it's still there, okay? So the heart can inherently still pulse away. And we'll be covering this in much more detail in the second module, because we want to know about these firing sequences of why particular nutrients work on that particular part. There's a very specific reason why vitamin B1, for instance, will work on the AV node. Very, very important why that is. And also vitamin B4, or adenine, which is a substance that they use for sinus arrhythmia in hospitals to steady the heart out. Okay, so when we've then the final part is the Purkinje fibers as these go round into the muscle, and the Purkinje fibers themselves have inherent rhythm. So if you cut off now the SA and the AV, the heart continues to beat, again a little bit slower, and then you cut all the Purkinje fibers, and then the myocardium contracts. So it all works. There's 5 different things that are firing inherently in there, and they all can get blocked. You know, toxins we know inhibit or block, and nutrients will help that to work properly. So it's very exciting, because when you pick this up and you get arrhythmias, you're not going to frighten the living daylights out of you like they used to. Okay, you can say, this is interesting. Let's do what Chris taught us, and let's see if we can actually find out what the person needs. So finally, as he described in the other picture, we got the chorda tendineae, which are like the tendons that hold and regulate by the papillary muscles. So there we got the chorda tendineae there that steady the valve, and the papillary muscles which pull the tendons there. But the tendons don't actually, the muscles don't actually shut the valves, they steady them. Right? What shuts the valve is the pressure of the blood in the chamber, in the ventricle or in the aorta and the pulmonary vessels. Okay, it's a back pressure which actually shuts them, and that's what you hear. So you can imagine, in that left ventricle, if you don't pump the blood out as much as you should do, you're not going to get a hard snap. Okay, can you imagine that? In other words, you're going to get a soft, wishy-washy thing, and that's what you get with a lowered first sound. But if you get a really powerful, big sound come out there, you think, wow, that heart is really contracted. What's made it contract quite so hard as that? So there's a reason for that as well. So what they found in heart sounds, and this is well documented in cardiology, is particular sounds which we pick up with the phonocardiograph. So the normal heart sounds is heart sound 1. That's the lub. Okay? We're all familiar with lub and then dub. So lub is the shutting of the valves in the heart chambers, and dub, or S2, is the closing of the aortic and the pulmonary ones. Okay? Again, must be simultaneous. Now, this from S1, the beginning of S1, or the contraction here, to the beginning of the contraction next time, which is roughly about 0.85 of a second. Okay? In that time, it's called the cardiac cycle. Right? So that's a complete cycle. When the heart contracts, it's called systole, or contraction of the ventricles. So between the first sound and the shutting of the valve in the aorta and the pulmonary is when the heart is working. That means the muscle is contracting. Okay? That's the working time of the heart. Okay? The rest of the time of the heart, it relaxes. Okay? You have a little rest. Okay? And that's called the resting period. Okay? So this all happens within 0.8 of a second. So what we're doing is we've got two parts. So the first part, remember, is the contraction or working part, and the second one is the relaxation. Are we plugged in for some sound? From here? No? Okay. So we'll come back and do the sounds a little bit later then. Okay, so let's go back here. So these sounds on the phonocardiograph, which we pick up and visibly look at, have equivalents in blood pressure. So when the blood pressure, when we read it, the highest reading, the 120, let's say, or whatever it is on there, is when the heart contracts, okay? And when the heart is relaxed, it drops down to 80, okay? So that's called systole, or systolic blood pressure, and diastole, which is the relaxation phase of that. And we get the equivalent here on the electrocardiograph. Remember, the electrocardiograph is the electrical functioning of the heart, not the muscle or the valves. And so we're looking at something different, but it's synonymous because the electrocardiograph will pick up these sounds and their electrical changes. But reading an electrocardiograph and a phonocardiograph is very different. So the first sound, and here comes the real simple bit that you can do your diagnosis. Where do I start with looking at one of these? And the answer is always the beginning. Okay? And you look at the first sound, you look at the second sound, and you look at the distance between the two. So most important, and you will very rarely see this, is the first sound should be 2 to 3 times louder than the second. Okay? Now, we've only seen this in a few incidences, so it's quite rare to actually get 2 to 3 times, and this is what you should get. Okay, this is the perfect. This is what you'd expect with the athlete. That means that that first sound is the shutting of the valves. Remember, between the atriums and the ventricles. That means that those ventricles are shutting really nice. Okay, so it should be 2 to 3 times. Now it's relative to the second sound. Okay, we can't measure on a phonocardiograph the amount of contraction, but we can see it in comparison to the second sound. So in other words, it should be 2 to 3 times the size of the second. The period between the second sound and the next first sound is twice as long as the first period, or the working period of the heart. Okay, so this is your normal. Okay, so if you've got this sheet in front of you. So this sheet is a summary of everything that we're going to be talking about or attempt to talk about today. Okay, so every condition that I'm going to mention is summarized on here, and this is really all you need. So I've given you all the information. So on one side, it says, on the top left-hand side, it says normal heart sounds. Got it? Okay. So you have a look at that, and you'll see, S1, which means the first heart sound, which is the contraction of the bicuspid and tricuspid valves, and then the cardiac cycle being the whole lot, and then the working period to the second sound. So you see there, the height of the S1 is 2 to 3 times the height of S2. All right, everybody agreed on that. That's what you should see. Okay? And the distance between S2 to the next S1 is twice the distance of S1 to S2. Are you with me on that? Anybody not sure on that? Okay? Because this is really, really important for understanding, you know, many of the problems. Sorry, can you just... okay, so S1, S2. So what we've got here is the distance from S1 to S2 should be half the amount, or double with the distance of S2 rather, to the next S1. Okay, everybody in agreement then? Okay, so therefore, if you know what is normal, and Dr. Goodhart used to say this a lot, if you can understand what is normal, you can then recognize what is abnormal. So everything else is abnormal. So if you base everything on that should be what is normal. So both auricular atrial valves must close at the same time. Okay, everything must. So the auricular ventricle valves and the aortic and pulmonary should close at the same time. That's your S1 and your S2. So the first one is the first sound and the second one is your second sound, or your dub. The rest period is longer, as this is the period that the ventricles are opening again, and should be twice as long as the closing period. So again, very clear there. Okay. So let's have a look at a few clinical conditions. And then once we've done that, we can begin to say, now I can see what is normal, what is abnormal, and then let's take somebody and let's record them and see what we think about it. Okay? So the first one on your chart there, on your laminate, is a diminished first sound. So this means the lub is not so much of a lub, but more of a lub, lub. And in some cases, when it's really serious, you may not even pick it up at all. Okay? And this is really serious when you've got acute severe hypertrophy, which you will get in total heart failure. So the normal on this is, I put on my charts here, the normal is always on the top of each slide. All right? So you've got the comparison. You would have to go back on your chart here to the first picture to learn that. Okay? So here we see dilation of the heart. This is when the heart gets bigger. Okay? And usually when the heart gets bigger, it changes its shape. Because it's sandwiched in there in the lung tissue, and it's suspended from the manubrial sternal joint here by a ligament, it'll change its shape. So as it gets bigger and loses its tone, it changes its shape. And as it changes its shape, the valves don't fit properly. Okay? So it's a bit like a car that's been in a prank. Okay? The car might look all right, but when you try to shut the doors, they don't shut properly. All right, you know that and you think, there's something wrong. Something's twisted a bit. And that's what happens with the valves. The valves then get a little bit, tension is wrong in there, and then they don't close properly, and then you get regurgitation or leakage because they don't shut properly. So dilation is a enlarging of the heart here, and you can see the size of the first sound is now not twice or three times the size of the second. Okay? The duration is less than 2/25 of a second. So we've got a shorter duration of the first sound altogether, so it's shorter here and shorter in height. Now, severe dilation, the second part of the sound down here, is very poor. So this is a person, you're getting a very small lub, hardly perceivable as far as a lub is concerned. And you get the dub, lub, dub, lub, dub. Okay. So in a really bad one, which you probably won't see of a heart failure, you won't even pick up a first sound really very much. Okay, so this would be a severe person who you probably won't see at this stage in your practice. So muscle conditions. So what we're going to do first of all is look at muscle. And these are probably the thing that you're going to pick up with your patients probably more than anything else. Okay, you'll pick up your valve problems, but the ones that we're really interested from our point of view is what you'll see is probably more you manifest in the muscle conditions than anything else. So the quality of the first sound indicates the quality of the muscle tone. So remember, the heart can contract on its own, and does if you take it away from the body. So how much contraction does it do on its own is what we measure with the first sound. All right? So in other words, if that first sound isn't high, it means the muscle isn't contracting enough. Okay? And when you think about that, that person with the diminished first sound there means they're only pumping a percentage of their ventricle chamber's blood out into the tissue. Okay, so you'll see this a lot with your patients, a lot. So if you get them to run round the block, and if they come back, you'll say, I told you so. And the incredible thing is, when you retest them, they're exactly the same. Okay? They still are really low. Exercise does absolutely nothing to pick that up. And so they work out, they do all this cardiac training and things, and nothing actually makes that heart contract more, okay? Because it's inherent in the rhythm itself. We've got to get right down into the mitochondria to get the muscle to contract. And most of you know that what actually occurs when the muscles contract is you get an influx of calcium into the tissue. What is different about the cardiac muscle tissue is it's calcium that goes in to make it contract, whereas with a lot of other muscle tissue it's calcium and sodium, but it's not sodium. Now when calcium goes in, to me, I interpret calcium influx into the cell. A, it has to be pumped out again, otherwise you turn to stone. And B, this indicates an excitatory neurotransmitter, because that's how excitatory neurotransmitters work, isn't it? Okay, remember the eye, ear, nose, touch and so on are all excitatory, and they use calcium ion channels and not sodium. Right? That means that the heart runs on excitatory neurotransmitters, which is aspartate and glutamate, not aspartame or monosodium glutamate, which can attach to the same receptors and trigger them off, which is why they do. Okay? And probably one of the biggest causes of tachycardia or arrhythmias are excitatory toxins within the person's diet. Okay, so that's the first thing, is you've got to have enough calcium. So if you're deficient in calcium, you simply can't get the muscle to contract properly. Okay? And a lot of people are deficient in calcium. But in this area of the world, it's not so much. And because we're high calcium generally, because it's chalk in southern England, what we tend to be is low in magnesium, in the calcium-magnesium ratio. But what is desperate is that a lot of people have actually got high calcium in southern England particularly, and it's not diffusible into the cells or the tissues. So they're getting high calcium, but they can't use it, so it doesn't get in. And why can they not use it? Because they can't maintain it into solution, okay, to take it across the cell membranes. And what are the cell membranes made of? Oils. Because most people are deficient in the essential fatty acids, desperately deficient in essential fatty acids. Because why? Because most people eat junk oils. Okay? Most of us eat junk oils. Okay? You say, oh no, that's not true. But by the time you've heated an oil, by the time you've left that oil and you've had it for a few months and you've forgotten to put the top on, it's gone rancid. Okay? And most people think, oh well, it's good oil, it's good olive oil. Olive oil is good for virtually nobody. Okay? Red people, it's a good, they need a bit of omega-9. But the green people and the blue people don't use olive oil or oleic acid. They use omega-6s. Oleic is omega-9. Oh, we get plenty of omega-6 in our diet. Do you? Bottle of sunflower here and, yeah, what other oil? Oh, olive. There's no omega-6 in olive oil. When did you ask yourself this question, actually have omega-6 oil? Good, cold-pressed, fresh, not rancid oil that you took raw and that you didn't cook with. Okay? When did you just do that? Probably most of you took the remedies, took the oils for that we suggest. But the majority of our patients is lucky if they get any oils. And yet they turn around and say, oh, you should have more omega-3 than omega-6 and so on. Most people's deficiency is actually omega-6 because they just have trans fats and they have oxidized fats. They don't have good quality oils. And trans fats and oxidized fats don't act in the same way as proper fresh oils, if you like. They don't allow that diffusible calcium to get into the cell. So just putting a person on the right oil, you can tell because within days their flexibility is improved, their overall flexibility. I know myself, if I can't bend down, go for a run in the morning, bend down and touch my toes, and I've really got to pump away at that, I haven't been taking my oil. And I have to admit, when Jill says to me, you haven't been taking your oil, have you? And I said, well, yes, I have. I took it. And she said, no, you haven't. And she's right, of course. So this is the question of getting the right types of oils. And most of our patients, it's simply a matter of the oils. And Jill's going to talk about that because oil deficiency and cardiac lesions, of course, are well known. But why? What sort of oil should a person take? What sort of ratio should they take of omega-6 to omega-3 and so on into the diet? Okay, so muscle conditions are due to a deficiency of calcium or an inability to get calcium into the cell, which is an essential fatty acid deficiency. Okay. The shorter the first sound is, that's the length between S1 and S2, and the higher it is in respect to the second sound, the better the tone. So the muscle tone depends upon being higher this way and shorter here. Right? So there you've got a good working heart. So we thought, we'll do some youngsters. They've got healthy hearts, haven't they? And then you look at their diet and you think, why have they got this all over the place? And in many youngsters, the heart is firing at different rates, here, there, it's all over the place and there. But when you feel the pulse, it's nice and regular. It's very interesting because you think, oh, nothing wrong at all. Pulse is regular, 72 cycles there. And you listen to the heart and it's thump, 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 and up and down and all over the place there. So we thought, well, kids aren't a good example because when you test kids, you find that their diet is full of potato crisps, chips, and all the bad oils in there, probably deficient in most of the good minerals there. And where the devil any of them get any vitamin E or vitamin B from is amazing, you know, because they just don't eat anything which is whole grain. And if they do, it's probably stale, so it's full of rancid fats. They don't have any fresh. Mum doesn't cook anymore. She just gets everything from the supermarket, ready-made food and so on. So you can begin to see why they're no good. So we tested the dog. The only reliable person is the dog in the end. And the dog was worse than the kids. And that was amazing as well, because a dog can alter its heart rate just at the slightest thought. You know, the thought that, am I going to be rewarded for standing there and have a stethoscope put on me? Where's the food? Where's the food sends the heart rate up. And, you know, when there's and you can tell, can't you, by the tail. Yeah. You know, the tail, if the tail's down between the legs, you know the dog's sad, and the tail's up and wagging. But also you can tell, of course, if the dog is fearful, there's anxiety and so on. And, you know, with dogs particularly, they smell it. They smell nice emotions and bad ones. They can smell fear in there. And that's why later on we'll be looking at how we treat that using aromatherapy to harmonize the heart and the brain. Because the fastest way into the limbic system is through the olfactory centers. But what you don't want is a bad smell in there because you'll react accordingly. But if you have a nice smell which is tailor-made just for you, it'll bring harmony to the heart and the head, which is what the whole seminar is about, is creating that harmony. So first of all, before we try to look for creating or what disharmony is, we've got to learn what they are, what the possibilities. So muscular conditions. With a failing heart, the sound becomes longer and lower in regards to the second sound. So the first sound goes down. In hypertrophied muscle, that means enlarged muscle, the first sound in relationship to the second sound decreases. Often the second sound is the same size as the first, so they both look the same. As the tone decreases, the second sound appears 2 or 3 times the size of the first sound. It gets tricky when you start looking at the phonocardiograph, and I've done this mistake initially when we first sort of started doing this, of which is the first and which is the second. Because I've assumed the big one was the first and the little one, and I thought, oh, there's no gap there. This person's about to have a coronary. But what it is, in fact, is a low first sound and a high second sound. So don't always base it when you look at the phonocardiograph of the high one. You'd expect it there, but we have to use a little bit of clinical intuition here, first of all. So we must listen to the heart, and rather than just pop the stethoscope on and into the machine, what we must do is listen for what is normal, which is lub-dub, gap, lub-dub, gap, all right? Just like on the cardiograph, lub-dub, gap. If we got lub-dub, 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 we've got something, you know, too close together there, okay? And if we've got any sound that we don't hear, but the most important is there a rest period? Is that person's heart having a rest? Is it lub-dub, lub-dub? If it's lub-dub, 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 that person's about to drop dead. Okay, remember that. Okay, they're not resting. You know, and you can't keep going without resting. You know, even your heart needs resting. Okay, okay, except the brain. I think my brain tends to go most of the time. Okay, so a totally decompensated muscle, the first sound is almost gone. So what gives muscle? You know, all the builders know what makes muscle, don't they? Pumping iron. The hormone that does that is testosterone. Okay, and it's been well documented now that low levels of testosterone will lead to heart problems. Okay, so what happens is that when the testosterone level goes down, you lose the tone of the muscle. Okay, you get flabby in the muscles. So it could be that a low first sound is an indication of low testosterone, okay, in both males and females. Okay? Don't think you're getting away with this. Okay, okay, it's males and females, low testosterone. Sometimes when a man gets to a certain age, women have higher testosterone than the man, okay? Which is why they start developing a few hairs around the chin and things. Okay? Maybe due to low testosterone. Doesn't necessarily mean, but the chances are, if you want to take that challenge that you're going to do to the testicles, okay, they'll cross-check. And that has a profound effect on a man. If you say, well, my heart's not so good there, Yeah, okay, and you need to take some whatever it is, but you cross-check it to his testicles and he goes strong, and then he thinks, he'll do something about it. So does he take testicular extract or does he take cardiac extract, etc.? Okay, so we'll learn which to do. So this may be, and probably is, an indication ultimately of low testosterone. Now, one thing we did discover, and this was quite worrying, Jill discovered this with your daughter, didn't you, when you did Charlotte, is that alcohol decreases the first sound very quickly. And we'll find this out when we start running some cardiographs, just how fast substances get into the blood. They start going in the blood in the mouth, don't they? We know sublingual absorption. You absorb things from the stomach, you absorb things from the small intestine. It does not take hours to get into the blood. Sometimes it's only seconds to get into the blood. And remember, it only takes 16 seconds from here to there. So it's even less from there to in here, okay? So the first sound drops very quickly after alcohol and up to 24 hours afterwards. Now, when you go out for the coffee break, what coffee does is unbelievable, okay? But it does the opposite, okay? Coffee, whoo, the sounds go up, particularly the second sound, as we'll say. So the first sound decreases. Remember what the first sound does? It's the contraction of the ventricle, particularly the left ventricle. And it lasts for 24 hours. So no alcohol for 24 hours before serious competitive sports. This is really important, okay? If you want to do it, you don't go on the booze the night before, okay? You can, but you probably won't win the race or whatever the performance is. Have that afterwards. Save it for, the winning, or drown your sorrows because you didn't win. Okay. Now, products. If you've got a small heart sound, okay. If the heart is beginning to, we could say the ultimate was failure, but let's call it a functional decrease. All right. Don't say functional heart failure because we're probably all in this stage because we rarely see a big one. So the most important thing that I've found in the probably getting towards 300 cardiographs that we've done, phonocardiograph. The most important and consistent one we found in the majority, not in all, is magnesium. That's no big surprise, really, is it? Because magnesium is there to make ATP, which is important, and it's also the antagonist to calcium, and it has many, many functions in the body. So what we're looking for probably is a series of nutrients for you to test. So what I've done on the chart here is I put those in very small writing, okay, so that you can these are clues, right? Don't hold this 100%, all right? But I'm going to give you, as we go through, roughly the sort of things that you would look for, the most common things. And it'll be all your old friends. There's nothing that strange in there. But you need some leads, because otherwise you'll email me on Monday or Tuesday and say, Chris, what do you suggest for this? I got somebody with a bundle branch block, and I say, well, look at your chart. Okay, that's the easy way. So, vitamin E. Vitamin E is very important for the strength of the heart, the integrity. It's an antioxidant. It supports the strength of the heart. And whenever in nature you see vitamin E, you find manganese. Okay? So in all foods which are rich in vitamin E, and there's not that many because most of them are it's taken out. And this is the thing, because we discovered that with some commercially produced oils, on the chart it shows that they contain vitamin E. But by the time they get to the shop, it's been removed. And it's been removed to sell you vitamin E as a supplement. And Jill's going to talk to you about vitamin E, because vitamin E is not just alpha-tocopherol. That's probably one of the least important bits of it. That's the antioxidant. But the most important aspects of vitamin E are far from just the antioxidant part. So we use the richest source of vitamin E, natural, which is 4 or 5 times the next one down on the list, which is wheat germ oil. So freshly pressed wheat germ oil, or WGO. Okay? So remember, WGO stands for wheat germ oil, is the finest source of vitamin E. Okay? And vitamin E in nature usually is accompanied. So the foods, like the wheat, the whole wheat, will be rich in manganese. Okay? Now, I've talked about, in the update, about an area of Texas called Smith Deaf County, where there's no dental caries. And when they've examined this area, what it's rich in, and it's rich in manganese. And manganese is to protect these people from dental caries. So dentists don't get very good jobs. But the wheat grown in that area gets the top price because it's the finest in the country as far as the minerals, but particularly the manganese. And the biggest source, remember, of vitamin E is wheat germ oil. Now, other oils and seeds will, of course, contain vitamin E, but by the time they get to an oil commercially, many of them had the E, particularly soya, as we see, removed. Okay? So we've got magnesium, vitamin E. Potassium, we'll see, comes into its own because potassium is like the brake. It is important with the firing of the heart, but it's more important as the brake. So we're going to look at that when we've got a fast heart. There are some people who have got to that stage where they need some protomorphogen, some heart tissue extract which contains the DNA to help them. Now, there's not many glandulars that I really am in favour of, because I think I want to get the person to make their own. You know, when their adrenals are not working, we want to try and find out what it is. But there are some people who have a severe adrenal exhaustion and do respond to adrenal tissue extract along with the nutrients. And there are people with the failing heart. And people have found that for many years, by eating heart, they feel better. But you've got to eat a lot of hearts. And it gets a bit much every day, you know, to have the same meal, at least in there. So heart extract, tissue extract, we obtain from New Zealand, which is generally considered to be one of the cleanest in the world, cleanest countries in the world, as far as toxins is concerned. So the heart extract comes from New Zealand, the tissue extract. So it's simply dried, but freeze-dried, not heated in the way. So it has all the nucleuses of the heart tissue there. So it gives the person the building blocks. And if the person is capable of regenerating, then that's going to be the substance. But do they need it or do they not need it? I don't know. The answer is muscle test, isn't it? Or whatever functional test you do. Okay? So I'm just giving you the options. So we'll give you samples of these so you can test these with your patients. Now, we may need to increase the tone of the heart, and what increases the tone we know is Crataegus. Crataegus is very good, or hawthorn. There's a number of substances, herbals, that will do this. Black walnut tincture, for instance, we'll see is another one. It helps, you know, with the stimulating testosterone. But certainly walnut has a big track record, hawthorn and black walnut, but hawthorn particularly is often given for cardiac weakness in heart failure. But they never give it in sufficient strength. You know, I've looked at heart formulas, and they contain a bit of heart tissue extract, a bit of hawthorn, some magnesium, some taurine, and so on. But the amount in a capsule is so small that really it's not going to be enough for that person. You know, they need 3 or 4 capsules of magnesium. They need, you know, 2 or 3 capsules of hawthorn and so on. So it's probably better to test with individual substances and give them individually, because they may need ratios as well. You know, they may need 2 of this and 1 of that, and next time you visit them, you know, it could be something slightly different than one hopes suggesting. Now, we've invented, and we'll come back to this one in a minute, a SMART, because we call these SMART, not to get confused with ordinary CoQ10, and as we'll see with RBs, we've called them SMART for the heart, as Clive said. So, SMART CoQ10, okay, wonderful product. We'll tell you what's actually in there, and we know that for myopathies or heart failure, CoQ10 has been used for quite a long time, because it gets right to the heart of the mitochondria. But when was the last time you got CoQ10 to muscle test? Not often, is it? Why? What's the reason? Because it's fat soluble. And how do you have it? As a powder. And how do you swallow it? With a glass of water. Okay? And when do you swallow it? Breakfast? Now, of course, when you muscle test it, it's at night time. Last thing at night it should be taken. Why do people not? They take it with food, don't they? Okay? If you swallow it during the day, you'll probably break it down and get very little use. You get some function from it. But if you take it last thing at night at triple warmer time, why do things show up at triple warmer time? Because they don't like hydrochloric acid. Okay? So hydrochloric acid is what's secreted in the stomach, inhibits the absorption of CoQ10. Okay, interesting, isn't it? So this is why I always muscle test when the hydrochloric acid is at its lowest, when you can swallow it. And you always take it with oil. This is now well known that they tell you, you must, if you want an effective result of CoQ10, take it with a spoonful of oil. Okay? Now, the next question we ask ourselves is, which oil? And that's the secret, because not any oil. You know, would sunflower be the same? I noticed that commercially it's always in rice bran oil. Okay, rice bran oil. But we also know that rice bran is full of arsenic. Okay, that's well documented as well. Never touch rice bran unless it's organic. If it's certified organic, but I haven't found a certified organic rice bran oil. Okay, you can get rice bran oil, but you can't get organic rice bran oil. for some reason. So I wouldn't use ordinary rice bran because it's got toxic metals, particularly arsenic, and that's no good for our blue people, is it? Because they can't get rid of that. Okay, so we found that there is an oil combination, and we'll tell you which one, which is suitable for everybody, that it dissolves fully in. Now the complex is different because the complex not only has that, but you need two other components to it. So that's why it's called a complex. Otherwise it will be a formula, but a complex means it's got several things which work synergistically. So we'll have a look at those a little later on. So we know that the amino acid taurine, now taurine is an amino acid, it's the most abundant amino acid in the whole body, but actually forms no protein. It's an amino acid, but it doesn't form any protein. But it's very rich in heart tissue, and it regulates the contractibility of the muscles. And of course the heart being a muscle is very, very important in this way. So it regulates heart contraction. So many companies and products have put taurine in, but taurine has a lot of influences. It conjugates cholesterol, doesn't it? It's the finest kind to make taurocholic acid. So this helps us to get rid of cholesterol, particularly oxidized bad cholesterol. So there's a lot of effective. Unfortunately, taurine really is only from animal origin. So this is no good for vegetarians. So some people may need to take a little extra, but we'll talk about that as we go on. So it's effective in the heart muscle contraction. So this is probably now, you've looked at the lowered first sound, and that's probably the most common thing you're going to see with patients, and it's the most common thing you're going to hear. And when you hear that and when you see that, it'll fit exactly with the patient's symptoms. Ask them what they're like if they've built off up the hill. Okay? So if they say, well, actually, I haven't built it off up the hill, or if I do, I get breathless, or I'm tired, okay? Then you say, well, that's exactly what fits with the heart. So when we look at the heart, we're really looking at the whole body, and we'll see we're not only looking at the whole body, but we're looking at the whole mind as well when we come back.